Shall I ask this thing? Now, why is it that, let me ask, why is it that coercion is deemed necessary for medicine? Because law is about coercion, right? And it's always been found necessary that when you deal with mental illness as a medical phenomenon, you need to coerce. Now, what is this thing? Because I've seen quite a few people who I know personally, anecdotally, who the moment they are taken to psychiatrists and are given medicine, the first set of responses they have is, we don't like this, it's changing me in a way we don't like. I know at least 4 or 5 cases personally which do this. So what is this link between coercion, law and medicine which is related to this lack of discipline, lack of obedience on the part of the seen as a lack of, what is it that is happening
this compliance, this whole concept of compliance.
And therefore, one is coercion, the other is covert treatment. So all these issues come together in that.
I would like to keep aside, these are 2 separate issues.
Okay.
One is about medicines, which we've been talking about this. It's there for every kind of problem, right? Medicine, whether to take it or not, whether to go for yoga instead, whether you to go for long walks instead, whether you want to change your diet. So these issues remain for the whole aspect of medication. The problem in psychiatry is that they insist and they do not give you any choice in the matter. And they find ways of ensuring that that particular chemical is shoved inside your mouth, whether you like it or not. Otherwise, they'll give you an injection. They'll take you somewhere else and give you an injection. So, or they'll put you under shock treatment or something. So, that part is very different for other healthcare patients, right? So, I don't think so there is a big problem about medication. For me, personally, I have a problem with all kinds of medication, including diabetic medication, hypertension medication, all kinds of medication. I have a problem with this. And so far as I have problems with all kinds of medication, I also have problems with psychiatric medication. But there are some who have benefited, provided that they have a chance to express themselves to the doctor and say, this is making me put on, I'm supposed to be like a 20-year-old, very nice looking woman, and then this made me like 70 kilos in 3 weeks. I can't carry this weight. On top of that, I know that by the time I reach 30 or so, I'm going to have diabetes, I'm going to have blood pressure, probably some cardiac events, and I don't want to die at the age of 40. This is the case with most psychiatric medication. You end up putting on weight, you end up gathering what is called iatrogenic diseases, but which are full-blown diseases. You have antipsychotics and it goes like this and it's irreversible. This is not iatrogenic. You just killed my personality. So and when doctors listen to this, they say, that's also part of your symptom. And then I try to tell them more, and then I get more angry, and then I get more angry, trying to explain to him, look, don't you see the change? Earlier I was walking straight, now I'm walking like this. Do you not see that as a change? And the doctor says, no, that's part of schizophrenia. But it is not. And so the voices that need to be expressed on the topic of medication, particularly antipsychotic medication, is not heard. And that's why it gets people more and more angry, and then people slap on more and more. Acha, itna anger hai to this is not depression. No, this is something else. So like this, they'll add more and more
lack of insight,
and then zombie. So one of the things that really I've got on my point is zombieism created by psychiatric medication. Zombieism is not created by diabetic medication. Diabetic medication will take your sugar levels so low that you can go into coma, but it will not make you a zombie. When your sugar is very low, you can become like extraordinarily expressive, angry and everything. So you're still alive and active. But these medications, if you see people, and communities are getting flooded by this. If you go to Bangalore, which is the den of global mental health, you will see communities are like, getting flooded with medicines and they're getting zombied out. In fact, at recent Calcutta only I asked, there were many doctors who had come, very good doctors, very well-intentioned doctors, who really do rational therapy, and I asked them, I'm really worried about the zombieism which is creeping into communities. Earlier you used to find such zombies only in the mental institutions. Now you're finding them everywhere. Wherever there is a DMHP program, you're finding zombieism. flat effect, then gait, and this all antipsychotic medication is prescribed completely irrationally and insanely. And there needs to be some voice. So those are my problems with medication. Many people benefit.
Yeah.
But just like, you can, abuse other kinds of medicines, you can also abuse psychiatric medication. And largely the experience from people with experience is that it is abused. Yeah. So what we have found for our community program is use it in the short term, like maybe 6 months, 7 months. But pump in a lot of other kinds of support systems, empower the families, start doing art. We do lots of arts-based therapies, drumming, music, where people cannot talk, you can use non-verbal means of communication. So we do a lot of that. So that brings me to the subject of disabilities actually. So those are the things that we do. We focus a lot on nutrition. I brought a little nutrition book, if some of you are interested, you can pick it up. After this session. Yeah, so we do a lot of nutrition, and one of my my pet theories, and we see that enacted every time in the Basti where we work, is it's the failure of the public health system. When you talk about medication, it's not just psychiatry. People need, tuberculosis treatment, which is rational. People need treatment for anemia. People need to be able to pick out malnutrition. So those are also the things. You need medication, yes. But what? Where anemia treatment is required, if you are giving antipsychotic medication, I have a big problem with that. Yeah. So those are the things that in the context of medication we need to talk about. So that is a bit different from the coercion part. The coercion part is, and I go back to your question, what about someone in dementia? And that kind of question can snowball into, okay, what about person in coma? What about person who is brain dead? So it can snowball into lots of other areas, which I think are really covered in the broader medical ethics framework. You already have a lot of discussion on this. So let those discussions apply in the cases where some person is so disturbed that you cannot engage them in a conversation and find out, okay, are they consenting, not consenting, what are they saying? I cannot understand. So those are the things. But for the large number of people who are like routinely mentally ill, so to speak, or routinely picked out in diagnostic terms as depression, schizophrenia, this and that, you don't have to do this. For the large part, what we need is, as people who are engaging them in these exchanges and conversations, we need to be skilled. Just because I don't understand you, I don't say you're crazy. I learn to understand you. That is my job, isn't it? So very often those frames are not there. The system is still very much run by the medical system, which tells you that, this is the box in which human beings fit. If they are like this, then that's not acceptable. So
I brought up the dementia thing because while they say that with advanced dementia they don't have insight and all that, but yet they are allowed to have their dementia clubs. They are allowed to form associations. Yeah. So somewhere the biological part of it, that there are some tangles in the brain and things like that, there's more sympathy towards dementia people than the mentally ill people. So, because I know that there are groups working, they're brought together in one place and they're encouraged in all that.
So now it's really good, and I think so that's where the linkage with disability is coming up strongly, that in some cases, Parkinson's, dementias, these are all the traditional mental health so-called disorders. But for them, certain kinds of groups are forming which are more disability inspired.
Yeah.
Some of the younger caregivers who started such support groups are also more inspired by the disability framework than the traditional ones. But the problem is that we have not touched the law yet, and so that is a big issue. So coming back to that first part of your question about why this coercion in the case of mental illness, for me again the response is that it is the colonial mindset that we have. If you read all the laws, you will find that people with mental illness are dangerous to self and dangerous to others. Yeah. This is so typically colonial. You'll find it in all penal laws, that they are dangerous to self. It's not just about the idiots and the insanes. You'll also find it about the paupers and the vagrants You'll find it about, of course, people accused of crime, that people are dangerous to self.
Dangerous individuals.
Yeah, so this whole notion of dangerousness is a big reason why coercion is applied. Not only that, there are many steps to this. Once we did a study on, there's supposed to be a community mental health program. We've had it from 1982, right? The law came in new law came in 1987, but we've had a mental health program, community mental health program from 1982. So one of the lawyers who interned with us for a year, he went around asking different so-called community mental health programs, how they deal with, this kind of situation. Somebody is really in crisis, and they said, no, they're all dangerous to self and society, and then we have to send them to the mental hospital. And many so-called community facilities had locked doors, grilled, and no. So it appears that if you have a post-colonial situation, particularly the Anglo-Saxon post-colonial, not the Dutch, the Spanish, or some Japanese or something, but if you have the Anglo-Saxon legal system, if you've inherited that particular legacy, then you've inherited like a vast number of provisions which the Anglo-Saxon legal system was the most evolved in this case. Right. The Dutch were not so, they were authoritarian, all right, but they did not develop, they were not institution builders in the way the British were. Right. And so Indonesia is very different. Indonesia was colonized by the Dutch. Philippines was colonized by the Spanish. So there, this does not exist that, if you're mentally ill, therefore you're dangerous to self. That mentality does not exist. Whereas you'll find it in most Commonwealth nations. There are Commonwealth nations where this law is obsolete. For example, in Bangladesh. There also you'll not find this, where it is working, you will find this mentality that people with mental illness are dangerous to self and society, and therefore they need to be in the closed door wards of a mental institution. So across Asia you'll find that and there are countries like Nepal, never colonized, but they try to copy India all the time. So then they get corrupted about mental health also. But then they don't have this thing that mentally ill people are. They have a hospital like this, walk in, walk out. They call it a mental hospital, and there are people who come and they go out. And there is no, there are no people who will catch them, you don't have to call the police, you don't take them before a district magistrate, all of that. So they're like, they're not okay, they are like patients only. They can't take their medicine, they'll go home. They may not have, they may do other things, they'll wander on the streets. It's fine. But then those countries are seen as backward and primitive.
Oh.
Yeah, the WHO is a big promoter of mental health. We confronted them this time, saying, okay, if you want, we told them you can't speak at INTAR until you tell us why you're proposing this mental health law everywhere. It is causing a lot of problems. When you have mental health law, unfortunately the colonial mentality is such that you can only develop a law like this. You cannot develop a positive rights law. You can only develop a law which is deprivatory. Yeah, that seems to be the legacy of law in mental health. So we challenged her quite a lot actually. And so she said, no, we don't have any issues. You create a policy, you don't create a law, that's fine for us. For the first time the WHO said it's okay. But if you read literature from 1970s onwards, the WHO has always insisted, it's one of the indicators of modern mental health system for the WHO that the country has a law. So that is about the coercion bit. This is a rather simplistic response.
No, I mean, one has to really get into it and what time. Just open the thing out.
I have a question about coercion. I mean, we have been talking about coercion that's more direct, that's kind of over, when somebody is pushed into the hospital, maybe because of certain kind of dissatisfaction in the family or at home.
Right.
But what about, heightened awareness of certain kinds of mental illnesses also being so freely available now? And mental health literacy, and what I suppose Ian Hacking would call this looping effect, where people make themselves aware of a certain kind of thing and voluntarily kind of enter this thing. Isn't there some other kind of coercion also going on when you meet someone like a neuropsychiatrist and then they'll say that, if you want, you can get into the medication, but it's a slight suggestion.
No, for sure, for sure. Yesterday, I think so, we were talking with Rohini, or we were talking about Deepika Padukone putting out a strong message that depression is a mental disorder and you've got to take your medicines.
Yes.
She's the ambassador for the Indian Psychiatric Association. We were hoping that she'll be the ambassador for the Bapu Trust. Unfortunately, no.
You're beaten to that.
Try and
Yeah, but that's the whole thing, the media is like really, global mental health is doing it through their professional academic media. They have so many open access journals today. The media is like hugely promoting the medicalization of communities, and I think so that as communities we need to be aware, I'm so glad that Himalaya, the herbal company, is also doing its bit of promotions, with herbals and supplements and everything. So I will hope that the media on that side will become louder than on this side. So people will have Brahmi instead of SSRI. Yeah. So the Ayurveda, again, it's a big phenomenon these days. Yeah, I think that's something that's really a cause for worry. And you do media studies. You should see. Jayashree wrote a really good one on psychiatric advertising, drug advertising in our recent book. But people have not explored this part. And typically, English departments, literary studies, critical theory departments need to really look at what's going on. I've never seen so many internationally peer-reviewed articles being published in open access. This man is spending tons of money. Where is the money coming from? For the first time in one of the collaborating networks, I saw Johnson & Johnson popping up. Only once. And global mental health has always decried pharmaceuticals, psychopharmaceuticals. Yet, I don't know what is the financing for this level of media work that they are doing.
Let me go ahead, please.
Last time I had actually a conference in Goa where
Little louder.
Graham Bhavik talked about it. So
Yeah, it was the 25th year of celebrations.
So Vikram Patel was saying that we have failed at filling this treatment gap, and we should also look at the preventive aspect. In the preventive aspect, we should look at child development, where most of the disorders start in early childhood. So we should push in more resources and make the child very resistant to prevent disorders. So is it like a shift in his policy, or?
I see the change in his thinking and in his vocabulary. He started out as a very, very, very committed community mental health man, which he continues to be till today. He has never spoken against institutions. That's my single biggest complaint with global mental health. He never addressed the elephant in the room in post-colonial countries like India, which is, despite all the jargon that is generated through global mental health or community mental health, we still have these, dozens and hundreds of institutions. So that is my only complaint. I think so. Global mental health has invested a lot of resources on preventive aspects, including psychosocial aspects, of interventions. So lay counseling, taking, support systems, door to door, the peer support system. So they have done quite a bit of research on that. But my complaint with that, so prevention is for sure, it's part of the global mental health frame. But without the specifics, I don't think so. Global mental health actually prescribes that this is the only way to go. They don't prescribe ethical values. So it is left to people to decide. There is no ethics which came out of global mental health. Mm-hmm. So if I said fill the treatment gap and take a community and flood it with medication, which is what is happening in the name of global mental health, then the leaders of that movement have to take notice that अरे बाप रे हमने prevention बोला ये लोग दवाई दे रहे सब. So they should stop and notice, but they don't do that. So they are like, everybody come, everybody join, and you all give medicines and you all do psychosocial and we are all happy. It's like that, and it cannot be. There is no direction, to their politics.
Sure.
Ma'am, actually I had worked in a psychiatric hospital for around a year. So what I felt is somewhere along this pharmaceutical companies' influence are much more than actually the psychiatrist's influence in medicating. Like there is always it seems like there's perks for selling this much amount of particular medication, and if there's something new then they will come out with some samples free.
Right.
And then immediately it has been administered on whoever they get, and then based on whatever the reports they get, again it's like if it's sold in much higher, then they get perks of going abroad and that, and every festival there is a special perk for the psychiatrist, and this kind of I'm wondering whether it's actually the psychiatrist's choice or whether it's the perks from the pharmaceutical companies which is
yeah, for sure.
moving things in a different direction. Because and there are psychiatrists who choose or opt out of particular medication, saying I tried this sample but it didn't work, so I'm not going to choose it. There's a favoritism to some medicines which have been effective, and there are some psychiatrists who are ready to try newer things and costlier medicines, so that they get the perks to go around the world.
For sure, for sure.
Yeah.
I think that's again an unexplored area, and it's true not just for psychiatric medicine, it's true for all medicines and general practice also.
It's not just also, sorry, let me interrupt. It's not just a question of honest and dishonest psychiatrists or doctors. It is that the science of medicine and the commerce of medicine are two independent vectors. Just because a person prescribes one drug rather than the other doesn't mean that that person is rational with respect to the question of insanity. There is a normative direction of the science of medicine. There is also a direction which comes from commercialization, and they don't form a single. They're not a unity which is without contradiction. There are contradictions there. Yeah,
no, sir. At this point, what I wanted to hint is sometimes the psychiatrist, after a particular sample, they get to know that these are all the side effects and it's coming in. Like sometimes they administer it to people who are only staying inside their clinic. Like if there's a wedding kind of thing. So then at that point, when they administer, they get to know that this particular medicine after a particular dosage, like maybe around 2 or 3 days, it's causing all these things for this many amount of patients. So then they can actually choose out of it. But then they find that like only some psychiatrists choose into it, and it's become a marketing kind of thing. So they're not seeing it in the right. The same way when ma'am was talking about this, there's one certification saying like the company asks when they get back that the psychiatrist has to write that this person is fit to work or this person is fit to study.
Yeah.
And can we come to institute or should stay outside but then can come. And then there is one line in between that saying that and I am responsible as far as if they are coming regularly to check and change their medication course.
Like a parole officer.
Yeah, like a parole officer. So they have to come again and again to monitor what they are actually having.
Yeah, so it's very high level of vigilance.
Yeah.